Hello guys, here we come. Part 2 of the pathogenesis of type 2 diabetes mellitus. There are evolutions in pathogenesis of type 2 diabetes mellitus with terms called triumvirate, ominous Octet, and sequence genes. So, what is triumvirate? It is nothing new, but we have already known that insulin resistance in muscle, liver, and beta cell failure, these three facts are collectively known as the triumvirate. In fact, the additional 5 factors are found to be involved in pathogenesis of type 2 diabetes mellitus. These are the fat cell causing accelerated lipolysis, the gastrointestinal tract causing ingredient deficiency or resistance, the pancreatic alpha cell with hyperglucogonemia, the kidney with increased glucose reabsorption, and the last but not the least, brain causing insulin resistance. All these 8 factors play an important role in development of glucose intolerance in type 2 diabetic individuals, and collectively, these 8 players comprise the ominous Octet. So, let's have looked into detailed pathogenic process causing ominous Octet. The number 4 factors, fat cells. In patients with type 2 diabetes mellitus and glucose intolerance, fat cells are resistant to insulin antilipolytic effect, resulting in increased plasma-free fatty acid concentration. Chronically elevated plasma-free fatty acid concentration stimulates gluconeogenesis, induces hepatic muscle insulin resistance, and impairs insulin secretion. All these free fatty acid-induced disturbances are referred to as lipotoxicity. Do we continue? The enlarged fat cells are resistant to insulin and have diminished capacity to store fat. When the adipocyte storage capacity is exceeded, lipid overflow into muscles, liver, and beta cells. In muscles and liver, there is muscle and hepatic insulin resistance, and in beta cells, causing impaired insulin secretion. In addition, lipid can overflow into arteriovascular smooth muscle cells, leading to acceleration of atherosclerosis. In view of the above, the first cell plays a pivotal role in the pathogenesis of type 2 diabetes. Collectively, the first cell and his 3 friends, muscle, liver, and beta cell, comprise the harmonious quarters, or perhaps more appropriately, the disharmonious quarters. The gastrointestinal tissues, the number 5 player. We have already known that there are 2 peptide hormones called glucagon-like peptide 1, GLP, and gastric inhibitory polypeptide, GIP. These 2 hormones potentiate insulin released from beta cells following ingestion of food. GLP-1 is released from gastrointestinal cells and GIP from gill cells, respectively, when nutrients reach the duodenum and upper jejunum. Studies have proved that more insulin is secreted when the glucose has been ingested orally when the above gut peptides are released than when glucose is administered intravenously, and this effect is termed the incretin effect, and GLP-1 and GIP are known as incretin hormones. Unfortunately, the incretin effect is diminished in type 2 diabetes. So the second thing is that GLP-1 is also potent inhibitor of glucagon. In type 2 diabetes individuals, there is deficient in GLP-1, which contributes to paradoxical rise in blood glucagon secretion. So, I would like to explain about the action of glucagon. Glucagon is a hormone secreted from pancreatic alpha cell, has opposite effect to insulin. Glucagon acts on liver cells and stimulate glycogenolysis and increase hepatic glucose production, and finally causing increased blood glucose level. So the nemesis player, the pancreatic alpha cells. The pancreatic alpha cells secrete the hormones glucagon. And I have explained about the action of glucagon in the previous slide. And then glucagon secretion from alpha cells is inhibited by 3 hormones. First, locally by beta cell insulin secretion, that is called paracrine effect, and secondly by somatostatin from delta cell, and third by islet amyloid polypeptide amylin, which is co-secreted from beta cells with insulin. And the third, the basal plasma glucagon concentration is elevated in type 2 diabetes individuals. So, the glucagon will cause increased basal rate of hepatic glucose production in type 2 diabetic individuals that was provided by Barrow-et al. So, by applying these mechanisms, drugs that inhibit glucagon secretion, exenatide, and drugs that block the glucagon receptor antagonists are likely to be effective in treating patients with type 2 diabetes. And the number 7 player, the kidney. So let's have looked into normal physiology first. In normal physiology, the kidney filters 162 grams of glucose every day. Among them, 90% of filtered glucose is reabsorbed by a high-capacity SGLT2 transporter in proximal convoluted tubule. The remaining 10% of filtered glucose is reabsorbed by SGLT1 transporter in the descending proximal tubule. Therefore, no glucose appears in the urine. And in diabetes, instead of dumping glucose into urine to correct hyperglycemia, the maximum reabsorbed capacity of kidney for glucose is increased. By applying this pathophysiology, SGLT2 inhibitor became key player in the treatment of type 2 diabetes. And the number 8 player, the brain. Insulin was a powerful appetite suppressant. Obese individuals, both diabetic and non-diabetic, are characterized by insulin resistance and compensatory hyperinsulinemia. However, food intake increased in obese subjects despite the presence of hyperinsulinemia. And the evidence have proved that the insulin resistance in peripheral tissue also extends to the brain. So, after we have looked into the detailed pathogenic process comprising the ominous Octet. So, the muscle, liver, pancreatic beta cells, along with fat cells, gastrointestinal tissues, pancreatic alpha cell, kidney, and the brain. All these 8 players are called ominous Octet. So, to summarize and to clarify, I have summarized with picture to explain the ominous Octet. Number 1, pancreatic beta cells decrease insulin secretion. Number 2, pancreatic alpha cells increase glucagon secretion. Liver increase hepatic glucose production. The intestines decrease incretin effect. Fat cells increase lipolysis. The kidney increase glucose reabsorption. Muscle decrease glucose uptake or insulin resistance in muscles. The brain neurotransmitter dysfunction and peripheral insulin resistance extend into the brain. So here is the end of the explanation about the ominous Octet, and in next video I will explain beyond ominous Octet Sweden system. So this is the end of the part 2 of pathogenesis of type 2 diabetes mellitus, and Thank you so much for your kind attention. If you like my videos, please subscribe, like, and follow my channels. So see you again, and bye bye.